in the beginning, but I
Oh,
think I just forgot. Okay, yeah.
I reviewed the lipid dyslipidemia so that I can watch
Yeah,
the
sorry, I
recording.
forgot. So,
Oh my
yeah.
god.
Okay, go ahead.
It's okay. Okay, for the management, so we have where we are. I lost.
You were doing
Uh,
investigations.
yes, so we have to look for because in Canada, like we have to like use minimal resources. Like so, that's not a way that we have to go. We are going to check these. We don't have to investigate by all these investigations. It depends on the clinical. Clinically, we will assess that what investigations are important at this stage.
Mhm.
So obviously, in the initial stages, INR will be okay. If he's doing well, so there is no need of INR. And this way, you are going to minimize the minimal use of resources. So they have mentioned continuum of alcohol use. I want to read it first, and then we will go for the management. What is the continuum of alcohol use? Uh, Patient is abstinent, low risk drinking, less than 2 drinks per day, less than 10 drinks per week for women, less than 15 drinks per week for men. This thing is important. That how many drinks per week, per day, this thing is important because in questions they like to ask it in this way by mentioning this thing that the patient is using this 2 drinks, 3 drinks, and then we have to go according to it. And at risk drinking, like what is the at risk drinking? If patient is having greater than 15 drinks for man and per week and greater than 10 drinks per week for women, this is the high risk drinking. Consumption above low risk level but no alcohol related physical or social problems. And then alcohol use disorder. What is alcohol use disorder? Physical or social problems, continued use despite consequences, inability to fulfill life roles, and legal problems, no evidence of dependence. Okay, this is, and medication side effects will go after it. So the management, what is the management? The intervention should be consistent with patient's motivation for change.
Sorry, Maya. Sorry to interrupt you. It's very good.
Yes,
But I just want to highlight one thing, which is very
yes,
important, which is the
yes.
AST to ALT ratio, which is more
Hmm.
than 2. Because I
Yes,
did a lot of U word questions, and especially for some the liver disease. And if you see
yeah,
the AST and the ALT ratio is more than 2, it's highly relative to alcohol use. So
yes.
keep that in mind. Yeah.
Yes, I mentioned it in the investigations, and thank you, doctor, for mentioning it again. And another thing is, there is also one thing, which is carbohydrate deficient transference (CDT). What is the significance of doing it? Like it indicate abstinence. If CBT is low, it means a patient is maintaining like abstinence, and if the CBT is high and patient is saying that I'm not using alcohol, then how we are going to see it? Like by CBT, CBT will be high in those people, and if the patient is abstinent, CBT will be low. That's the very important thing which they have mentioned in psychiatry. And
It's
what
if
how
the patient will be drinking more alcohol than the CDT or CBT.
CBT. We will go for it after from doing it from here.
Okay.
We are going to do it from psychiatry. So
Okay.
calm down. We will do it.
Okay.
So management intervention, as this session is recorded, that's why I wanna don't break the flow of it. Intervention should be consistent with patient's motivation for change. Individualized counseling and regular follow-up is crucial. So follow-up is very important. 10% of patients in alcohol withdrawal will have seizures of delirium tremens. So how much delirium tremens and that seizures is prevalent? That only 10% of patients on alcohol withdrawal. Okay, and Alcoholics Anonymous 12-step program, outpatient day program for those with chronic resistant alcohol use disorder, family treatment, Al-Anon, Alateen, and screen for spousal and child abuse. So this comes in the BA in the therapy, Alcoholic Anonymous step program. refer to specialist or inpatient program. So that's the outpatient program. And when we are going to go for the refer to the specialist for inpatient program for alcoholics, then these are the indications: dangerous or highly unstable home environment, severe medical and psychiatric concern, addiction to drug that may require inpatient detoxification, refractory to other treatment programs. So patient is like not improving and these things are present, then we have to refer. We are not going to admit the patient. We have to refer for the inpatient program, as we are not a specialist. We are just family physicians. So keep this thing in mind. Pharmacologically, pharmacologic therapy is diazepam for withdrawal, and these things are very good in psychiatry, that withdrawal symptoms and all. And disulfiram antabuse impairs metabolism of alcohol by blocking a conversion of acetaldehyde to acetic acid, leading to flushing, headache, nausea, vomiting, hypertension if alcohol is ingested. Available in US, but it's no longer used in Canada. So disulfiram, which is a very famous drug, is not used in Canada. So this thing is very important. And disulfiram shows the side effect when patient is still using alcohol. So this drug is not very good and also not used in Canada. Naltrexone, competitive opioid antagonist that reduce cravings and pleasurable effects of drinking, may trigger withdrawal in opioid dependent patients. So this thing is very important. Naltrexone and acamprostate are the famous drugs, as we all know, for the alcohol dependence. And but this thing is very important. Acamprostate is glutamate receptor modulator that also reduce craving. So one thing is very important about naltrexone, that it's the opioid antagonist. So we should do the urine drug test for if the patient is having the opioid dependence and opioid abuse history. Why? Because obviously, if the patient is still is having opioid use disorder and we are giving him naltrexone for if obviously these sort in these cases we have to we have to take very good history, so that we know so that we will be know about it, that patient is using any other drug or not. So it's for the combination. If the patient is still opioid using and he is also using alcohol and we are giving naltrexone, this is like not a good practice, because naltrexone will cause opioid withdrawal. And in this way, the patient is going to have withdrawal symptoms and all the delirium tremens and all these things which they have mentioned. So see psychiatry PS 29 here. After that, we will go for it. And some adverse medical consequences of problem drinking are gastrointestinal or gastritis, dyspepsia. I'm reading the sidebar. Gastritis, dyspepsia, pancreatitis, liver disease, bleeds, diarrhea, oral esophageal cancer, cardiac or hypertension, alcoholic cardiomyopathy, neurological Wernicke-Korsakoff syndrome and peripheral neuropathy, hematological or anemia and coagulopathies, and other are trauma, insomnia, family violence, anxiety, depression, social family dysfunction, sexual dysfunction, and fetal damage. So these things are like adverse effects of drinking. And prognosis, relapse is common and should not be viewed as failure. So relapse is very common in all alcohol and smoking cessation. So we should keep it in mind that it's not like it's not don't consider it that it's a failure. So again, encourage patient. Monitor regularly for sign of relapse. 20 to 30% of patients with alcohol use disorder exhibit spontaneous improvement over 1 year. Okay, and 60 to 70% of individuals with jobs and families have improved quality of life 1 year post treatment. So 1 year post treatment, there is a good response. So now want to read this all from psychiatry. It would be good, Maya, if you open it on the screen too. It will be easy for all of them.
Yes, I did.
Okay. So now I'm reading alcohol from psychiatry. First, history. History is very important. Cage questionnaire, the famous Cage questionnaire, which we have read a few minutes ago. And on history, what is important? Validating screening questionnaire for alcohol use disorder. And C, ever felt the need to cut down on your drinking? A, ever felt annoyed at criticism of your drinking? G, ever feel guilty about your drinking? E, ever need a drink first thing in the morning, which is the eye opener. For men, a score of greater than 2 is positive screen. For women, score of greater than 1 is a positive screen. So we have read it before that score of greater than 2 is positive, but for women, score of greater than 1 is considered positive. If positive case, then assess further, like we have to dig in to distinguish between problem drinking and alcohol use disorder. So these things are very important. These two are two different things. That is problem drinking and alcohol use disorder. These things we should differentiate these two things. And side now I'm reading Canada's low risk alcohol drinking guidelines. Moderate drinking is man 3 or less drinks per day. So if the man is consuming 3 or less drinks per day, it's like it's okay. And if he is consuming less than 15 or 15 per week, like it's okay. Or for women, 2 drinks per day, 2 or less drinks per day is fine. And if she is drinking less than 10 drinks per week, it's like all right. And for elderly, 1 or less drink per day. This is the low risk drinking, and it's like it's okay. And what is the confabulation? Now I'm reading the sidebars. Confabulation, the fabrication of imaginary experiences to compensate for memory loss. Make sure to ask about other alcohols, which is mouthwash, rubbing alcohol, methanol, ethylene glycol, aftershave may be used as a cheaper alternative. So we have to keep this thing in mind, and we have to ask about other alcohol use. And again, this is the standard drink, which is not important. And now I'm going for the biochemical markers of prolonged alcohol use. Yeah, scroll up. uh, yes, it's here. Biochemical markers of prolonged alcohol use: elevated liver function test, which is AST, ALT, and gamma GT, and MCV, and carbohydrate deficient transferrin, which I mentioned before. And AST ALT ratio should be greater than 2:1, and elevated gamma GT are suggestive of alcohol use. So now I am going to read alcohol intoxication. So, what is alcohol intoxication? Throughout Canada, the legal limit for impaired drinking is blood alcohol level greater than or equals to 0.08%, which is greater than or equals to 80 milligram per deciliter or 17.4 millimole per liter. These values are important. So, what is the range in Canada for impaired driving? That is 17.4 millimole and 80 milligram per deciliter, and back of 0.08%, and which is typically it reached after four drinking in women and 5 drinking in men in a period of 2 hours. So this thing is important. 4 drinks in women and 5 drinks in men in 2 hours. At this level of alcohol is achieved, and it is impaired this will impair driving. Most signs of intoxication are present over at greater than 21.7 millimoles. So greater than 21.7 millimole and 100 milligram per deciliter, signs of intoxication will occur, will present. And what are the signs of intoxication? That these are altered perception, impaired judgment, ataxia, hyperreflexia, impaired coordination, changes in mood, personality, prolonged reaction time, and slurred speech. These are the signs of intoxication. And later on, respiratory depression and arrest can occur with greater than 60 millimole per liter. These are the values in millimoles, not milligrams. They are telling in greater than 60 millimoles, patients will have respiratory depression and arrest, and 90 to 120 millimole per liter intolerant drinkers, like who have the history of chronic use of alcohol. So we there's a sidebar of delirium tremens. No, first we should rate the management of intoxication, and then after that we will go for the delirium tremens. So management is stabilize the patient if there is reduced level of consciousness or if the patient is continuously vomiting, assess the airway and respiratory function. That's the same ABCD of the emergency medicine. And administer IV crystallite fluids if evidence of volume depletion or shock, correct electrolytes and hypoglycemia, monitor for signs of alcohol withdrawal. So what signs, the signs which I have mentioned, these are of the alcohol intoxications. I haven't mentioned the signs of withdrawal yet. So keep this thing in mind. What I've mentioned are the signs of intoxication, and what I am telling you the management is the management of intoxication, which is the stabilization and IV crystalloids and electrolytes, and the monitor for signs of alcohol withdrawal following detoxification in patients with alcohol use disorder. Okay, now I am going for alcohol withdrawal, which is the alcohol withdrawal is the medical emergency. We should treat it as an emergency, uh, because it will present as psychosis in patient. So this thing is very important, and it is considered as medical emergency. Occurs within 12 to 48 hours after prolonged heavy drinking. So when it will present after 12, if so, for example, if the patient is he drank a lot of alcohol overnight, and now after like 12 to 48 hours, this withdrawal will occur and can be life threatening. 50% of middle class functional individual with alcohol use disorder have experienced alcohol withdrawal. 80% in hospitalized and homeless individuals. So it's more in hospitalized and homeless individuals, because obviously the heavy drinkers, when they are hospitalized, they don't have the opportunity to drink. And in this way, their alcohol withdrawal will present in the hospitalized patients. And obviously, homeless people, when they don't afford to drink, they will present in this way. So, alcohol withdrawal can be described as having four stages. So, stages are for withdrawal. However, not all stages may be experienced. Maybe patient is have at stage one, stage two, stage three, stage four. Like this is for our own age. Clinically, patient don't present in this like manner. So autonomic stage one is onset within 4 to 12 hours after last drink. The shakes, tremor, sweating, agitation, anorexia, cramps, diarrhea, sleep disturbances, anxiety, insomnia, and headache. These are these all symptoms will present in 4 to 12 hours, and that's the stage one. What is stage 2? It will present in 12 to 24 hours alcoholic hallucinations, visual, auditory, olfactory, or tactile hallucinations, which will present in 12 to 24 hours, which is stage 2. Stage 3, it will present in onset will be in 12 to 48 hours. Alcohol withdrawal seizures, usually clonic, non-focal, and brief, can occur as early as in 2 hours after alcohol consumption. So it can present early on. So this thing is very important. And this is stage 3, not usually present that is seizure stage. We should remember this thing in this way, that this is a seizure stage. The generalized tonic-clonic seizure stage mostly occur at 12 to 48 hours, but can occur as early as within 22 hours of alcohol consumption. Stage 4 is onset 48 to 96 hours. Delirium tremens, that's the stage 4. Tremens is stage 4. Confusion, disorientation, delusion, hallucinations, agitation, tremor, autonomic hyperactivity, diaphoresis, fever, tachycardia, hypertension. So these are the symptoms of delirium tremens, which is a stage 4. So to make it easy, how I remember this thing is these stages. Stage 1 is autonomic stage. Autonomic, like patient is having this autonomic symptom, tremor, sweating, agitation, anorexia, cramps, diarrhea, all these symptoms. Stage 2 is sensory, like hallucinating, visual, he's hallucinating. So these are the sensory symptoms. And stage 3 is seizure stage, which is generalized clonic stage. And stage 4 is delirium tremens, which is very famous. We all know stage 4 is very easy. Delirium tremens. So there is a sidebar of delirium tremens, alcohol withdrawal delirium. autonomic hyperactivity, diaphoresis, tachycardia, increased respiration, hand tremor, insomnia, psychomotor agitation, anxiety, nausea, vomiting, tonic-clonic seizures, visual, tactile, auditory hallucination, persecutory delusion, 12 to 24 hours it will present. uh, uh, no, 12 to 24 hours, visual hallucinations will present, but this delirium tremens will present in 48 to 96 hours. Okay, course almost completely reversible in young, elderly, often left with cognitive deficits. So in young, this stage is reversible. This alcoholic withdrawal is reversible, but in elderly people, this is not reversible. Some sort of cognitive deficit still remains in the elderly. This is very important. And mortality rate is 20%. If patient is not like if we are delayed diagnosis and that the mortality rate is very high, which is 20%. Management of alcoholic withdrawal. So what we have read before was the management of alcoholic intoxication, and what we are reading now is the management of withdrawal. So withdrawal is for which we read the 4 stages. So now management of withdrawal is that monitor using the Clinical Institute Withdrawal Assessment for Alcohol CIWAA scoring system, which is this is used for the monitoring of alcohol withdrawal. This is very important, and we should keep this thing in our mind. Areas of assessment include, they have made it like it's the mnemonic chant as TAV. So physically 5, psychological cognitive 2, and perceptual 3. So that's the scoring system basically. So physical symptoms will be paroxysmal sweating, headache, fullness in head, agitation, nausea, vomiting, tremors. And psychologically, what will be there? Anxiety, orientation, clouding of sensorium. Perceptual, what will be the symptom? Tactile disturbances, auditory hallucinations, visual disturbances. All categories like these all are scored from 0 to 7, except orientation sensorium 0 to 4. Maximum score of 67, and mild less than 10, moderate 10 to 20, and severe greater than 20. So we don't have to remember this, like how they don't ask it that calculate the score. So but what they do is they like to mention the score, and then they ask us the things like what is the management, and then so this thing is important, which is mild less than 10, moderate 10 to 20, severe is greater than 20. So check for signs of hepatic failure, which I've mentioned before that this thing is very important. If there are signs of hepatic failure, then we are going to test INR. So what are the signs? Ascites, jaundice, and coagulopathy. And they have there is a table which is for Clinical Institute of Withdrawal Assessment for Alcohol, treatment protocol for alcohol withdrawal. So that's the protocol, and now I'm reading this protocol, which is basic protocol. What is basic protocol? If the patient, any patient who is coming to us with withdrawal, we have like diagnosed it as in withdrawal. How we are going to treat? Basic protocol is that we are going to give diazepam 20 milligram per oral, 1 to 2 hourly. If the CIWA score is less than 10, observe 1 to 2 hours after last dose and reassess on CIWA scale. And then thiamine 100 to 250 milligram are intramuscular, then 100 milligram per oral unsteady for 3 days, and folic acid. Supportive care, which is hydration, nutrition, and electrolyte replacement. This is the basic protocol of alcohol withdrawal. And now there is a specifications. If the patient has history of withdrawal seizures, then if the patient on history, if there is any history of like withdrawal seizures, so what we are going to seizure is the stage. Tell me, what is the stage of seizures? I mentioned it before. Are you guys with me?
Stage 3.
Yeah, that's the stage 3 of seizure. So what is the management? Diazepam 20 milligram per oral every 1 hour for minimum of 3 doses, regardless of subsequent CIWA score. So in the basic protocol, CIWA score is important, which is point less than 10. But in the if the patient is having history of seizure, regardless of the CIWA score, we are going to give diazepam in this way, which I've mentioned. And if patient is elderly, greater than 65, or patient has severe liver disease, severe asthma or respiratory failure, then how we are going to manage? We will use short acting benzodiazepine, and we will use lorazepam 1 to 4 milligram per oral and intramuscular every 1 to 2 hours. And now if the patient is hallucinating, which is the hallucination is the stage 2, right? So if the patient is hallucinating, what we are going to give? We are going to give haloperidol, which is first generation antipsychotic, 2 to 5 milligram intramuscular or per oral every 1 to 4 hours, maximum 5 doses per day, or atypical antipsychotics, which is olanzapine and risperidone. This can be used for acute hallucinations. And along with it, we can use diazepam 20 milligram, 3 doses as seizure prophylaxis, because we all know that haloperidol lowers seizure threshold. So that's why we are giving it with diazepam. So what we are giving haloperidol for that hallucinations, but we are not giving it for seizures. So because for seizures we are only giving diazepam, and if the patient is hallucinating, then we have to give haloperidol along with diazepam. And when we are going to admit the patient, still in withdrawal after 80 milligram of diazepam, that's the red flag that patient is not improving after 80 milligram of diazepam, which is a very high, patient should improve. But if the patient is not improving and still he has the withdrawal symptoms, which I have mentioned in 4 stages, then we are going to admit the patient. If the patient is having stage 4 delirium tremens and recurrent arrhythmias or multiple seizures, then we are going to admit the patient. And if the patient is medically ill or unsafe to discharge, like this is our, here comes our clinical expertise, then we have to assess that patient is if the patient's condition is good, so we can discharge it or we should manage it in inpatient. So that's the table. And now moving forward towards that Wernicke-Korsakoff syndrome, which is very famous syndrome for